Okay, so good morning, good afternoon, good evening, everyone. My name is Dr. Edward Kwakyi. I'm a nephrologist and a senior lecturer with the University of Ghana Medical School in Accra, Ghana. I'll be your moderator for today. I'd like to welcome you to today's session of GlomCon Ghana, or GlomCon Ghana's seminar series, which occur quite regularly, but in recent times, not as regularly as we'd like to. The main purpose, GlomCon Ghana is part of GlomCon Global, and our main purpose is actually to curate knowledge in nephrology, particularly in glomerular disorders, and bring that knowledge to the doorstep of all cadres of medical practitioners and further the agenda of nephrology globally. GlomCon Ghana just happens to be a chapter in the huge scheme of affairs, the huge global scheme of affairs of GlomCon. And I'd like to welcome you today to our session with an esteemed speaker in Dr. Michelle Hladunewich.
Thank you so much. If I knew you were going to read that much, I would have sent you a much shorter bio, but thank you for the lovely introduction. So, my role here today is talk to you about pregnancy and glomerular disease, because this is GlomCom. And I can assure you that everything here is really based on clinical knowledge. As you know, there's not the best evidence in pregnancy. We're getting there. We're getting better evidence all the time. But a lot of what I share will be a little bit based on, personal clinical experience. I actually have been doing this a really long time. I'm getting old now, so I've probably counseled well over 1,000 women with pregnancy. Our clinic sees 100 pregnant women plus every year. So our experience is really quite diverse. I do have a disclosure. I have funding from Roche Pharmaceuticals to study the angiogenic factor specifically in CKD, and I will be sharing that preliminary study with you today because it is quite interesting. So reproductive freedom is defined as the basic right of all women to decide freely and responsibly the number, spacing, timing of their children, and to have the information and means to do so, and the right to attain the highest standard of sexual and reproductive health. We know this is eroding in many parts of our world right now, but women with CKD, therefore, are the highest risk because they have these same rights, but they have to so carefully plan their pregnancies within the context of their disease. So they're a very at-risk population. And as nephrologists, we're not actually the best at managing them or helping them and support them in these very difficult life decisions. This was a cross-border survey of 154 nephrologists. It was actually done at Canadian and American academic institutions. And what we found is that most provided reproductive counseling less than one time per month, and 15% didn't even bring it up in the preceding year. When we sort of asked why we're not reaching out to our women and helping them with these tough decisions, it really came down to sort of a lack of comfort with the subject matter. So hopefully talks like this that we do through GlomCom can improve that level of comfort and help us manage our very complex young women. But when we asked them what they were uncomfortable with related to glomerular disease, they didn't know how to counsel with respect to outcomes by CKD stage, either pregnant women or fetal outcomes. Counseling on the optimal timing of pregnancy and glomerular disease was challenging for them. Managing immunosuppression was 50% of them felt comfortable. Managing nephrotic syndrome was actually quite low during pregnancy. And although diagnosing preeclampsia was greater than 50%, it's so challenging in our renal population that we'll spend some time discussing it today. So for many women, not all, but for many women, even most women, having a child is a life goal, and women with CKD are not an exception. Sometimes when we're uncomfortable with subject matter, we have a tendency to aggressively counsel for or against, or not counsel at all, and that really puts them at significant danger. Oops. And CKD is a progressive journey. So it's actually our job as nephrologists and obstetricians and internal medicine doctors to assist with family planning at all stages of CKD. It is our job to help them find the safest window of opportunity, especially because we're dealing with remitting and relapsing diseases. And we should be discussing and maybe even encouraging pregnancy at earlier stage CKD. But no matter what we're doing, it's our job to initiate the conversation. We often wait for them to bring it up. And if they have no knowledge of what the risks might be, they may not plan their lives in accordance with what they would like to achieve. Some of the most sort of angry women that I've seen in counseling over the years are the ones that didn't know that it was going to be a problem for them, because they said if they had the knowledge, they would have planned things a little bit differently. So we have a response.